to be part of the speakers panel for the PPA North Luzon meeting. And thank you to Dr. Efren Balanag for the invitation to join you tonight. So tonight, I have been tasked with discussing lower limb deformities in children, spotting what's normal and what's not. So pediatric orthopedics is a special branch of orthopedics, and it's very dear to our hearts. And this is because we know that children are not just small adults. Their bodies are still growing. The responses to injuries and conditions they have are different. And the communication skills, emotions, and cooperation of the children are different as well. And perhaps not the least, we all know that when you talk to children, you're not just dealing with the children themselves, but also with their parents. And a lot of times, a lot of the concerns with lower extremities have to do with the parents' concern about their children's condition. So what are important for us to note when we take history of patients with lower problems? We'd like to know what is the specific concern. Is it pain? Is it a limp? Is it an asymmetry or a deformity noted by the parent? When does it manifest? Does it happen all the time when the child is walking? After an injury happened? What is the duration of the symptoms? Has it been since the child was born? Is the child of walking age? Is the condition improving or worsening? And lastly, we'd like to be able to tie this in with the patient's medical history and the family medical history as well. So when you talk about pediatric orthopedic lower extremity conditions, we'll start first with the most proximal part, the hip joint. And perhaps the most important hip pathology we should pick up is that of the developmental dysplasia of the hip, or DDH. DDH is a spectrum of disorders of hip development, which can run the gamut from instability, subluxation, dislocation, and subsequent dysplasia of the hip as well. The old term for this was congenital dislocation of the hip, but we now know that it is a developmental process which can span from both the intrauterine period to the early postnatal period of the child's growth. There are several risk factors which have been identified as being predisposing to having DDH. This includes breech delivery, where the position of the foot is hyperflexed upwards, being a firstborn female, presence of a high birth weight, presence of family history of DDH, presence of oligohydramnios, and multiple pregnancies. A lot of this have been grouped together in a theory known as fetal crowding, where there's very little space for the child inside the womb, and thus the position of the child is forced into extreme flexion and more instability for the hip. There are also extrauterine factors associated with hip dysplasia. For instance, in the picture on the left, this is that of a northern Canadian Indian baby, which is wrapped straight. Now, they're strapped to a cradle board, and the hips are maintained in extension and adduction. And they have an unusually high prevalence of DDH in their tribe, in their group. Whereas in other areas where the babies are carried with the hips flexed and abducted, this is a more stable position of the hip, and it allows the hip to develop more properly. So luckily in the Philippines, I think most of the areas we've seen carry their babies this way, strapped around the bodies of the mother and with the hips abducted and flexed. How do we screen children with possible hip dysplasia? So during the first 2 months of life, the neonatal period, we usually have to pay attention first and foremost to associated conditions. We'll go into this later. Clinical signs at this point are fairly few. There are some provocative tests that you can do, like the ortolanis, which is trying to reduce dislocated hip, and the Barlow's, which is trying to dislocate a subluxable hip. Now, X-rays are not so useful at this age group because the femoral ossification center has not yet developed, and so we have to rely on other modalities like hip ultrasound. So what are the associated conditions which are seen in patients with DDH? This include the presence of plagiocephaly, or an asymmetric appearance of the face, torticollis, where the neck is bent to one side because of a contracture of the sternocleidomastoid muscle, presence of a pes calcaneo valgus, where the foot is actually deformed upwards, metatarsus varus, and a knee extension contracture. So if the patient is presenting with any one of these other deformities, which is usually more easily seen, we do have to screen them for the presence of a DDH as well. So in a patient who is very young, sometimes the earliest symptoms can be something like this. When you examine the patient, take off his swaddling clothes and his diaper, you'll see an asymmetry of the thigh folds. And this may point out a possibility that something else is wrong inside. The Gagliazzi sign is fairly easy to do. The patient is lying straight down and the hips are flexed 90 degrees. And if the patient has a unilateral dysplasia of the hip, you will see that the side which is displaced is usually shorter than the other side. However, if both sides are affected, you may not be able to get such an obvious appearance. A bit later on, when the patient is 3 to 12 months of age or starting to walk, you will be able to examine them from the back and still note the same asymmetric thigh folds, no? And as seen in this picture. You'll note when you do your physical exam that there is limited abduction of the hip. The Gagliazzi sign may still be positive, and you'll note that there is a leg length discrepancy of the child. And you'll see that when you try to move the hip, comparing both the usually telescopes back and forth, which means that it's fairly loose. And at this point, you can start doing radiography to assess the patient. Limited hip abduction is probably the most reliable sign of dysplasia in children. So when you compare the abduction to the degrees and try both sides, and when you have you'll be able to suspect side is possibly dysplasia. Some conditions like abnormal posture, hyperlordosis, or when the patient walks with a limp or is seen as an abductor lurch, and the Trendelenburg sign. When you try to ask the patient to stand on one leg, they are unable to support the leg as well. And like you mentioned, when they walk, they have a short leg limp. And remember the hip adduction contracture, it still progresses until this age. So when you try to do hip abduction, you're unable to do it on the affected side as well. So the important thing to recognize about DDH is that the treatment varies per age group, and it varies in the sense that in very young patients, less than 12 months old, you'll be able to treat this close to the Pavlik's harness, which is just a strap that you wear, a brace that the baby wears, and you can actually carry him around in this harness. By 12 months to 18 months, you may need to do something like a close reduction and a hip spica cast. Above 24 months, usually you will need to do an open reduction, doing surgery to manually take out all the gunk that has block reduction, and then opening and reducing it, and then putting a patient in a spica cast. But after 3 years, it becomes more difficult because secondary deformities have occurred. So you will need to do either femoral or acetabular osteotomies to reduce the hip. So these are examples of patients we've seen. This was a patient we saw at 1 year and 2 months of age, and we were able to do a close reduction in hip spica for this patient. And now she's at 5 years old, and we've been able to maintain her reduction. This is another patient who came to us at 3 years of age, and because her age of onset was slightly older, we had to do a varus derotation osteotomy aside from the open reduction procedure. So she's still doing very well, and is in an abduction brace. This patient, on the other hand, was seen at 10 years old. She was diagnosed at infancy, but for reasons like the parents were afraid to have surgery done, we got the referral late. At 10 years old, as you can see, the femoral head has no longer developed normally. And what we had to do was what we call the shelf osteotomy of the acetabulum, or try to increase coverage of the acetabulum. And she also had to go a secondary leg lengthening procedure. We did an Ilizarov procedure to lengthen her leg by roughly 10 centimeters. Unfortunately, she's at 21, 22 years of age now and starting to feel hip pain. At this point, we want to keep her hip preserved to try to do a hip replacement procedure in several years' time. So in DDH, remember, early diagnosis is key and allow us to do intervention. If you can get them as early as possible, you can put them in a brace like this. So second, we go to the knee disorders. In the knee disorders, it's important for us to try to note what is normal and what is abnormal. And for us to be able to recognize this, we actually see what are the two most common conditions that we're asked to look at. Usually we're asked to look at patients with either knock-kneed or pikit, genu-valgus, or patients who are bow-legged or sakang or genu-varus. But in order for us to understand this, we have to know and look at what the normal growth pattern of children are. Infants less than 2 years old are naturally born with a varus uh, appearance of the lower extremities. And at 2 years old, this shifts and the patient goes into the hypervalgus, no? And then as patient reaches 6 to 8 years old, position. So you look at the values and you'll know what the maximal levels of normal are. So for varus, you accept up to 15 degrees in 10 degrees in the third year of life. This is what they look like. No? So when you do have angular problems, we've discussed what the physiologic appearance are. Now we try to look at some of the pathologic causes, no, of angular problems of the knee. So what are the signs of having an abnormal knee? You may have an abnormal knee if the patient remains bow-legged beyond the third year of life. Remember, we expected this to resolve by 2 years old, and by 3 years, they should actually be going into valgus. Another sign of an abnormal knee is if it's an asymmetric appearance. No? If one side is more deformed than the other. And third is if the deformity is associated with pain. So if these three signs are present, you may be dealing with an abnormal knee pathology. So at this point, again, take a look. If the bowing, no, if the patient is below the 5th percentile for height for the age group, and there's a marked asymmetry between left and right, there may be a pathological process going on. And again, if the patient remains knock-kneed or in-toed over 8 years of age. So varus presenting beyond 3 years, knock-knees presenting beyond 8 years. So just to show you some examples, this is a 2-year-old patient that we saw. Initially, the parents were concerned about the genu-varus or bow-legged deformity, and we just watchfully waited on this patient. And by the time the patient was already 4 years old, the deformity had corrected. You may or may not use braces for this patient. This is another patient, teenager, no? Again, with various deformities of the knees. Things to look out in this patient. Again, he's too old already to be having a various deformity of the knees. Secondly, he's obese, no? And the skin color is actually a predilection. In dark-skinned races, they are more common to find Blount's disease. And this is exactly what the patient had. The patient had Blount's disease, which is a progressive tibia vara deformity, and the patient underwent a guided growth procedure where staples were placed across the physis to allow the medial side of the knee to continue growing. And as the patient's deformity resolved, the staples were eventually removed. No? In more severe cases, like in this particular case, sometimes you actually need to do a corrective osteotomy, as is done in this picture, to correct the deformity. So we go now to the lower leg and the foot. And some of the things that we often see by the parents are pigeon toes and flat feet. These are common conditions that are often normal. No? The feet are turned in, which are called pigeon toe deformity, and the flat foot deformities. Now, in-toeing is common in babies and toddlers. And almost all the time, this resolves without treatment. Now, when they start to run, they're actually in-toed a little bit and they walk. And then as they grow up, this usually resolves. By itself, it's not painful. It's not associated with arthritis or any other deformity. And rarely, it can be associated with knee pain and problems if it persists beyond the childhood age. This article from the Journal of Pediatric Orthopedics actually hinted that people with in-toeing are faster runners. No? So they actually show that people who have in-toeing may actually be better off than people with straight or out-toed feet. The treatment for in-toeing is usually no treatment in most cases. In patients with very severe deformities, they may need bracing, no? And surgery in some very severe cases is rarely done. So the other side of the deformity is the out-toeing deformity, where the toes are pointed outward. This is less common than in-toeing, and it's usually caused by twisting of the hip, the thigh, the shin, or the foot. And unlike in-toeing, Outtowing is usually unlikely to improve over time. No? So with this, if it's not causing any problems, we don't do anything. But if it's asymmetric, for instance, or it's causing problems, then they may need to undergo what they call a rotation correction procedure. So here we see that again for outtowing, usually they rarely require special care. Now let's talk about a flat foot condition. If you talk about flat feet, all infants actually have it. When you look at the feet of infant, they're naturally flat. Have it, and more than 15% of adults have it. Flat foot often growth, not related to disability in any form or manner, and it's not affected by special shoes, inserts, or braces. Have a flexible flat foot if you use if you have to go and watch from behind the tiptoes and then this is a stiff flat foot, and this may be associated with some congenital tarsal coalitions in the foot. So other foot pathologies to consider include clubfoot and the calcaneo valgus feet. So let's talk about the calcaneo valgus. We know it's the most common foot deformity at birth, where the foot is flexed upwards, no, against the tibial shaft. Most of the time, this will resolve spontaneously. You can usually also advise the patient to do stretching exercises to correct it downwards. More importantly, though, is it is associated with hip dysplasia. So if the patient has a rigid calcaneo valgus deformity, the patient should be followed up for the presence of a DDH deformity. Clubfoot is the opposite deformity. Now, clubfoot is one of, again, the most common deformities we see in the childhood or neonatal age. It happens at an incidence of roughly 1:1,000 live births. No? And it's more common in born genetic go in some families, a lot of times it doesn't. Of clubfoot, usually period of manipulating the foot and casting them. And then this can be followed by a period of percutaneous anatomy. Then the is up to the 4 or 5 years age. If treatment is begun as possible and compliance is good, we have an upward of 90% success rate with clubfoot treatment using this Ponseti technique. Just to show you some patients we have of clubfoot, the patient we saw at birth, no, with a clubfoot deformity of both feet. You can see the feet are rigidly turned inward. It is fairly hard. Several serial casting procedures to gradually correct the deformity and eventually underwent a percutaneous tenotomy. This is done with a small, just puncture incision to cut the tendon, and the patient is casted in the corrected position. And these are the pictures and after the tenotomy, and eventually when the patient is now in the brace. And when she learned to stand, her feet are now plantigrade with minimal deformity. This is another patient we had who was born with clubfoot. Patient came in slightly older, I think past 3 years of age. We started the Ponseti treatment for this patient. And right now you can see the patient is already walking very well. We still keep the braces during naps and nighttime up to 4 to 5 years of age. So this is another patient we had who came to us relatively late, past the age of 1, and she had a neglected clubfoot. She had been treated in another hospital, but they didn't continue treatment, and she's starting to walk on the outside of her feet. So this is a very painful deformity and very disabling for her as well. And after the treatment, this is her with her feet. She did the same serial casting. She's older than the other kids, so we had to bribe her with chips and crackers to let us cast her feet. And after the casting period and tenotomy period, now she's walking plantigrade with her feet as well. So the problem with this patient is when we started the pandemic, she lives in Ambuklao and she couldn't come back to the clinic for her brace. So she had outgrown her brace, and we could see from the pictures they were sending on Facebook that her intowing was starting to recur, from the deformity was starting to recur. So we arranged with our group of volunteers to have a bicycle brace delivery service where we actually, there you can see the foot in towing. We actually went back to them in Ambuklao, did the stretching, fitted her for a new pair of braces, and had her wear the new braces. So at this age, when they're walking age, we don't keep the braces full time. They're usually worn at naps and nighttime, but until the age of 5 to prevent any deformity from recurring. No? And this is done with the Miracle Feet Foundation, which is helping our clinic. And here she is now. So for Clubfoot, we want to see them as young as possible. Fortunately, in North Luzon, there are several Miracle Feet Clubfoot clinics already. We started from 2 clinics last year to now over having 8 clinics across the North Luzon area. You can refer your patients to the ones nearest you, and treatment is provided free of charge for the casting, the tenotomy, and the bracing. These are the contact details of our Miracle Feet Clubfoot Clinic in Benguet, and we'll be happy to take care of your patients for you. Maraming salamat po, and thank you for your time and listening tonight. Thank you.